All right, so the topic is colonic stenting. Does anybody want to stent right now, or we're good? Same disclosures. This is more like a practical approach talk about stenting. I don't know how many of you do stent large bowel obstructions. The typical indication is a tumor obstruction. So that's by far the most common reason why we throw in a stent, but occasionally you don't know what it is. Sometimes it could be like a diverticular obstruction, a vascular ischemic. Those are not really great indications. Colorectal cancer in 8 to 16% has the complication of an obstruction, or at least partial obstruction. And all the other symptoms are at the moment irrelevant. If we have somebody who comes in with a large bowel obstruction, then we have essentially 5 options. One is to take the patient to surgery and perform a segmental resection with or without proximal diversion, with or without on-table lavage. Or we do a subtotal or total colectomy with primary enterocolonic anastomosis or enterorectal anastomosis. We can do a discontinuous resection, also referred to as a Hartmann resection. We can just do a proximal diversion, do a loop colostomy upstream, or, and that's the topic today, we can throw in a stent either as a definitive treatment or as a bridge to a semi-elective surgery. Possible indications, as mentioned before, are malignant obstructions, a primary tumor, a colon cancer recurrence, metastatic disease, poor operability. We don't really know what the role of a stent is for benign obstructions. Whenever we have M&M conference and present a leak, even though we never have a leak, but if we present one, our foregut colleagues ask, why don't you put in a coated stent? And we always say, yeah, we don't. But potentially one could think of it. Contraindications for a stent, in our opinion, is if you have an asymptomatic patient, don't put a stent prophylactically. If you have signs of a perforation, probably not the right place. And if you really have somebody who has absolutely no residual life left.